Before we begin, we must define what constitutes access. Access, most broadly defined, is the ability of an individual to readily utilize healthcare services when needed. These services should be affordable, convenient, acceptable, effective, necessary, and timely. Access also means that an individual has a usual source of care, and he or she need not worry if and when he or she has access to this care. In discussing access, it is also important to note that access is key when looking at health and healthcare delivery. Firstly, access is a key determinant of health. Secondly, it is a benchmark for determining the effectiveness of medical care delivery. Thirdly, measuring access can help decipher if the distribution of healthcare is fair and equitable. And finally, access itself is linked to overall quality of care. Anderson, 1968, believed that on top of simple need, some conditions induce individuals to use more medical care than others. These are called predisposing conditions. These conditions include socioeconomic status, race or ethnicity, age or education, religious preference, sex, sexuality, or gender, family size, and later this model was expanded upon by Ade et al. 1980 to include policy. Policy includes major governing healthcare initiatives such as Medicaid, Medicare, and CHIP. Pachansky and Thomas, 1981, describe access to care as having 5 main dimensions: availability, accessibility, accommodation, affordability, and acceptability. The first of which is availability. This is if services are available to the individual, and if the individual has enabling factors necessary to access these services, such as social services or transportation made available to them by the provider. This also means if the individual has access to primary care 24/7. The second of which is accessibility. Accessibility is whether an individual can get to their care. Do they have transportation? Is there care near them? And if there is care near them, is the care appropriate for their medical needs? The third is accommodation. Accommodation refers to how healthcare is organized so that patients can actually access care. Can individuals make an appointment? Are the established hours such that individuals can attend appointments? Can a patient be seen within a reasonable time frame? The fourth is affordability. Can the patient pay for services? Does the patient have insurance? If the patient has insurance, are they able to afford their copays and deductibles? And if they don't have insurance, how will they pay? The final is acceptability. This is the relationship between the patient and the provider. Are the patient and provider able to work together? Is the patient empowered by the provider to be an active proponent of his or her care? And are patients accepted no matter if their race, religion, or any other social factor? I will now link access to an issue near and dear to my heart, the access to dental care. Dental care is maldistributed, meaning that there is a lot of dental care near urban centers and not a lot of care in rural settings. So let me pose a hypothetical to you. Let's say you're an individual in rural Appalachia and all of a sudden you have a toothache. Ouch. The nearest metropolitan center is 3 hours away. So how are you going to get there? Well, the first option is to take a car or to have somebody drive you. But you don't have a car and no one is available to drive you at this time. Another option is to take public transportation. But because you live so far away from a metropolitan area, there is no public transportation available to you. The final is to hire someone to drive you or to rent a car. But you cannot afford this, and you cannot afford this and also afford dental care. So what are you to do? Cue in the dental therapist. Dental therapists are mid-level providers, similar to physician's assistants in medical practice. Dental therapists work under the direct or indirect supervision of a dentist, sometimes utilizing telemedicine. An advanced dental therapist is similar to a regular dental therapist, but they have a more advanced role. They can distribute medication, and they can also perform simple, non-surgical extractions. Dental therapists were first utilized in underserved areas and areas that had scarce dental access. There are 3 states that allow dental therapists: Minnesota, Alaska, and Maine. 54 countries and territories worldwide, including those that are highly developed, utilize dental therapists and have a record of providing safe and effective care. Dental therapists increase access for children, those who are disabled, the elderly, racial or ethnic minorities, immigrants, and migrant workers. So, what can a dental therapist do exactly? Well, generally, a dental therapist can provide services where a dentist need not be on site. These services include health promotion instruction, oral cavity charting, radiograph, prophylactic treatment, placement of a temporary restoration, and administration of local anesthesia and nitrous, to name a few. There are also procedures that can be done with a dentist on site. These include cavity preps, temporary crown placements, restorations, and other more invasive procedures. These would be utilized if a dentist is available, but their services are spread thin. The APHD believes that adding dental therapists to the dental team would meet the growing need of oral health amongst the underserved, and as an organization has proposed a curriculum that will meet those needs by creating a 2-year educational program that will allow dental therapists to offer a high standard of care. Currently, Minnesota has a 2-year master's program for dental therapists after completing a bachelor's. Looking at the work of dental therapists have been seen to perform at an acceptable level and with short-term restorative outcomes that are comparable with those of an actual dentist. Minnesota has employed the use of dental therapists, and preliminary findings show the effectiveness of this implementation. Early research in Minnesota found that dental therapists served 6,338 new patients. Research found that on average, 84% of these patients were enrolled in public programs. Additionally, 1/3 of all the patients seeking a dental therapist experienced a reduction of wait time for appointments. Along with a reduction in wait time, some patients found an added benefit of reduction in travel time. The implantation of dental therapists in such clinics suggests that they may in fact reduce ER visits in vulnerable populations. Having the dental therapist on the clinic team resulted in an increase in productivity, decrease in patient costs, and an overall increase in clinic savings. Dental therapists increase the geographic span of care, provide a safety net for those who cannot obtain care, and increase access to care. So these all sound like great benefits, but why are dental therapists causing such a stir in the dental community? Well, there are a few reasons. The first reason has to do with education. Dentists, as professionals, are upset because dental therapists do not have the same level of training. Dentists have to go through a doctorate program, while dental therapists only have to go to a master's program and can complete some of the tasks of a dentist. So are patients who are underserved receiving the same quality of care if these individuals have only gotten a less of an educational background? The second has to do with cost. While perhaps a dental therapist might reduce the overall cost of care, there's not a lot of reduction in convenience. This is because dental therapists can only do certain procedures. So this individual still has to go to a dentist even if they have access to a dental therapist. In areas where a dentist is available, this might put a strain on the patient-dentist relationship, and this lack of convenience might deter people from seeking dental care. The final has to do with market saturation. As I said previously, currently, dental therapists are only utilized in areas that are either underserved or there is a scarcity of dental care. However, what is really stopping a dental therapist from working in a metropolitan area? Well, there are 2 issues with this. The first being that it doesn't actually reduce the gap in dental care. Those individuals who did not have access before will still not have access, and it will create competition in the dental market. So how can we create some sort of balance where dentists and other healthcare professionals in the dental profession are happy with including dental therapists, but dental therapists also aren't breaching the scope of their practice? The first option would be to limit the scope of practice in dental care of where they can practice, meaning that dental therapists would only be allowed to practice in underserved areas or areas that have a low dental distribution. The second option would be to increase education. Dentists complain that dental therapists do not have enough education to perform their duties, so we would increase the clinical education, such as providing a residency program for dentists similar to that of a medical residency or a dental residency. The third option has to do with including dental therapists, but also maintaining their specific role. Dental therapists are trained technically, but not diagnostically. Dentists have an intense medical background that dental therapists do not. So any diagnostic decisions or complex medical cases should be left only for practicing dentists. Thank you for your time, and I hope you enjoyed the presentation.